I'm Dr. Michael Miyazaki, and we're going to talk about the Endocator. The Endocator is new technology that allows us to do our root canal therapies with greater predictability. And I really like it because when I'm done with my root canals, I can feel confident that things are going to heal up and not blow up, which we don't want to have happen for our patients. So, does your office provide in-house endodontic treatment? And I will tell you, if you do, congratulations. I think it's really a really important part of our practice because it's so much more convenient for our patients. They trust you. And yeah, we do refer out, but the patients really trust you first. And when you refer them out to somebody else, they have to develop that trust and comfort. The other thing about doing root canals within your practice is that it generates added and in many cases needed revenue for the practice. We just want to make sure we do a good job when we do the root canals. But the big question is when you do a root canal, do you feel like they heal or do you have trepidation? You know, you've done a root canal 6 months ago and now the patient comes back, you're taking an x-ray. Are you worried that maybe it hasn't healed? Maybe they don't experience pain, but maybe that periapical area isn't healing up. And that's what this presentation is really going to be about. How do we have predictable treatment, predictable healing so we can sleep better? So in the endodontic, what I call triad, there's three different parts, right? We have to access the canal system. We have to clean it out biomechanically with our files. Then we do microbial control. So we get in there with our irrigants and we're using our files to remove all the tissue that's within the canals. But today, what we have as an added feature of our treatment before we do the third part of that triad is the obturation or the sealing of the canals, is we can verify that we have the canal system cleaned out. And that is what the indicator is really all about because research shows that if we don't remove the bacteria from the canal system and we don't disinfect the canal system properly, that we're not going to have successful healing in most of the cases. Whereas if we do get good cleanliness of the canals, we're going to have greater success. So what we have to do is we have to remove all the bacteria. Now we've known that. You know, when I learned how to do a root canal 40 years ago, I knew I had to get all the tissue out and all the bacteria out and have it basically bacteria free. So we would follow our protocols and we were protocol driven. You know, I'd use my files, my irrigation and my obturation system that I became trust. But how did I know? How did I know that I had all the bacteria out? Because when I go into these canal systems, and remember the goal of a root canal with the files is to clean the canals out and to shape it, to remove the vital or necrotic tissue and the different microorganisms that might exist in that canal system and their byproducts. And then using this file, I'm trying to shape the canals to provide enough space so I can irrigate properly and that I can then obturate or seal that canal up with my gutta percha. Now, I know that if I fail to do that, the patient could most likely have postoperative pain. It's not going to heal. I could get a new infection that requires retreatment of that root canal, or worst case scenario, we lose the tooth. And if that happens, we lose revenue and we lose sleep. We all feel bad if we do a procedure and it doesn't work out for the patient. Now, when I go into the canal system with my files, what we do is we find those main canal systems. But what about all the lateral spaces? What about the bacteria on the canal walls? Are we getting that cleaned out? So my question to you is, what is really clean? So, you know, one of the best ways to dirty canal system is to take the files down in there because we create a lot of dental mud, all the filings from the walls as we scrape, the tissue, the bacteria that's in there. And did you know that if you did the filing, maybe with some water to lubricate your files and to rinse out the debris, that we would still leave behind living bacteria because we're not using the right irrigants. And I think you realize that when you're doing the root canal, you can't see true cleanliness. We have all the bacteria, all the tissue, all the blood out of that canal system, either with an endodontic microscope or with a radiograph, right? You can't see the clean. And so I think that's one of the big things we have to remember is we want to clean the canal system and we want to confirm before the obturation of that canal system that we have the bacteria out. So here is acrylic block, and just showing how as we take that file down into acrylic block, look at all the mud. That's acrylic mud. But imagine this were a tooth. That'd be dental mud. That'd be bacteria. That would be pulp. And so when we do these root canals, we are creating all this mud, that cloud that's within that canal system. And how do we get that out? And how do we ensure that there's no bacteria in that? And then if we look at the tubules along that canal, the bacteria can hide in those tubules. And so you have probably seen some of the lectures on irrigation, and that's really critical to get all that mud out and to open up the tubules and then to get rid of the bacteria. So we would advise you to follow an advanced irrigation protocol, and that would be using pharmaceutical grade equivalents to sodium hypochlorite. You might use smear off, which is a combination of 2-in-1 of your EDTA and your chlorhexidine. But you want to make sure you're using pharmaceutical grade irrigants to clean out the canals. And then as you're using the irrigants, we want to activate it, because passively putting irrigants down into canals doesn't always get rid of the mud and the bacteria. So what we want to do is we want to activate it, and ultrasonic deactivation has been shown to be very effective. Here's that in a solution of soda water, and you can see how that ultrasonic energy creates this cavitation energy, and that's going to mix everything up to force out your irrigation into those lateral canals. And what we're going to do is we're going to use the sodium hypochlorite or the chlorextra to dissolve the pulpal tissue and disinfect the canals. We're going to use our EDTA to remove the smear layer from the canal walls to open up those lateral spaces. And we're going to go back into sodium hypochlorite and use our activation to get rid of all the bacteria that's hiding in either the lateral spaces or the tubules. So before I do my obturation or seal the root canal up, it's almost like we do a little prayer, because I hope that I have the bacteria out of the canal system before I seal it up. I hope I have the bacteria levels down to a level low enough that the patient's immune system can handle any bacteria that we may leave behind, or maybe that apical bacteria that's outside of the canal system that we're unable to remove with our files and our irrigants. But the patient's immune system can go in there and combat that bacteria load, and we will have healing and success. But if we leave too much bioburden behind, not out of a lack of competence, but we just can't see it. And we have to acknowledge that every tooth is unique, the shape of the canals, the lateral spaces, the tubules. And so people will tell you that, yeah, not every root canal will heal up. And many times when it doesn't heal up, it is because we've left some bioburden behind. And then the patients suffer, and we almost as much, right? Because we don't want that for our patient. So I'm going to move this photo over. How do we put the odds in our favor? We use our endodont protocol to clean and shape and to irrigate, to disinfect and dissolve the tissue and disinfect the canals. But what else could we do? Well, you probably have heard of ATP, adenosine triphosphate, when you were taking your classes back in college. But ATP is basically a universal energy currency of life. It powers the cells. And so any living bacteria, living tissue, living cells will have ATP within it. So what we do today is we use ATP as a detection marker. It is a marker of metabolic activity, not just tissue left behind. And you can reflect that there's viable bacteria still in the canal, there's active biofilm in the canal, or some inflammatory exudate. And what we want to do is we want to get our ATP levels to zero. Now, when we try to identify ATP, we don't know if that ATP is from bacteria or host cells, like maybe some red blood cells, but it shows that there's living biological burden within that canal system, and we don't want to leave that behind. So we're trying to eliminate this ATP producing bacteria and the ATP driven inflammatory signaling, because part of having successful endodontics is basically taking that ATP level in the canal down to zero through our chemomechanical debridement and for obturation. So what we're going to do is we're going to disinfect that canal so there's no bacteria, no tissue, no host cells like red blood cells in that canal system that would have any measurable ATP. How do we do that? We use the Endocator, and this is the exciting part. The Endocator is the first and only chairside device that detects residual contamination invisible to microscopes and the radiographs. And it does this in just 10 seconds. And so it's amazing to have this sort of test that we can use while we're chairside doing our endodontic procedure that doesn't disrupt our workflow. So what are we going to do? Is we're going to do our endodontic protocol. We're going to trust that we're getting the canals clean, and then we're going to confirm that cleanliness using the Endocator, and that's the power of the Endocator. So we depend on our endodontic protocols to ensure we have the clean canals, but there's a lot of variables. You know, did the practitioner use magnification or not? And even with magnification, we can't see if we get all the bacteria out of the canals. What kind of file system was the operator using? What kind of irrigants did the operator use? Did they activate it with sonic, ultrasonic, or maybe lasers to activate and cleanse the canals? How long did the operator have to do this procedure? I've talked to some doctors who tell me that within their practice, they have to complete a molar root canal within 20 minutes. And other doctors have an hour and a half to 2 hours to do that. And then the experience of the clinician. So there's a lot of variables, even if we follow a set protocol. And then again, every tooth is unique. So if we don't get the canal bioburden down to zero and we followed our protocol, it doesn't necessarily mean that we haven't done our very best. It's just that this tooth can be unique. There could be lateral spaces, lateral canal spaces that we cannot clean out. So before obturation, what we recommend now is you determine what your endoscore is. The endoscore is an indication of the amount of ATP that's left in the canals. The ATP in turn is an indicator of the amount of bioburden that's still within the canal system in that tooth. And what we have to realize is that the reading of our endoscore being lower is better than if it's high. If it's high, that means there's a lot of ATP, there's a lot of debris that has ATP in it, and that could be living tissue, it could be exudate. So how hard is it to use the Endocator? It's really easy. What you do is you do your endodontic protocol, you finish with the irrigants, then you take a syringe with about a milliliter of sterile water and you just rinse out the last of your irrigants. And then whatever sterile water is left in there, you take another syringe and you withdraw a little bit of that. You put that sample within a tester, the little tube that you see with the reagent in it. You put a few drops of your uh, sterile water that you drew out of that tooth into that tester. You put that in the swab. It's like a little Q-tip swab. And then you depress the tester so the orange top goes all the way down and the little Q-tip goes into the reagent. You put that in the Endocator, that little desktop device, and you wait 10 seconds as it's doing its thing, and you get a score. Now, when the score comes out, the lower the better because the ATP that it's measuring is either from bacteria, nerve tissue, blood, or possibly even from saliva. Low scores from 0 to 25 mean that the root canal is basically clean. You have it so clean now that if you tried to culture any bacteria out there, you probably could not. It's that clean. Scores that are higher, between 51 and 100, means that there's still a lot of ATP in there. And now it's up to your clinical judgment. Do you obturate or do you go back? And maybe you do some more instrumentation, rinsing, activation, give it some more time to see if you can get it cleaner. But if we have a bioburden of 1 to 25, we're good to go. So again, what do? We use our protocols to clean, and then we confirm. So it looks kind of like this. So this is an extracted tooth, and what I'm doing is I'm just rinsing out some sterile water. Now you can see this syringe, we're withdrawing some of that sterile water. We put that into the tester, and sometimes it's just a couple drops. And then we take the little tester, and it has a little Q-tip and we place that into those drops so it absorbs that test sample we took out. Then we press that Q-tip all the way down, into the reagent at the very bottom, and we shake it around for about 10 seconds so that it reacts. Once that reagent in the very bottom dissolves and our sample has reacted to it, we're ready to put it into the Endocator. And the Endocator, through fluorescence technology, will be able to measure how much ATP is in our sample. So here we put it in, and 10 seconds later, it's going to give us a score. In this case, it's a score of 67, which is, for me, too high to even consider obturation yet. What we would have to do is go back in there, maybe file a little bit more, maybe irrigate some more, maybe activate that irrigant some more before we actually obturate. So this is just showing these little Endocator test swabs and the Endocator on the left-hand side. So just another example of just showing how it's used. Once we put that test tube in there, then we hit test, and when you'll see this little countdown, and in 10 seconds, you'll see what our score is. So in this case, we were doing a real root canal here. I got a score of 36. Now, 36 would probably be okay to obturate, but I wanted to see if I could get that score lower. So I went back, I just irrigated a little bit more, activated that irrigant, rinsed it out with some sterile water. Then I withdrew some of that water and tested it for a second time. And this time I'm just going through showing you, I put the little test sample in there. We activate the Endocator, and in 10 seconds we got our score, and we went from the 30s down to 5. Now that I'm at the 5 level, I'm good to obturate because we've cleaned out the system with our protocol and we've confirmed that it is clean. So remember, 1 to 25 means low bioburden. We should be good to seal it up. We've cleaned it out and we've confirmed it. So with the Endocator, what I ask you, or we ask you, is what's your endo score? Now, the protocol you follow, you just do this test at the very end, and then you clean and confirm. It's really easy. You saw how fast it is. Now, a question that I get from doctors is, well, what if my score is higher than 25? Well, again, the objective is like in golfing. We want a low score. So did you put a rubber dam on? If you don't have a rubber dam on and saliva's getting into your canal system, that will contaminate it and your scores will go up. Do the canals look clean and dry before you test? If there's any tissue left behind, bleeding, or purulence, we need to stop that, because if we test that, of course, we're going to be high because we're going to have a lot of bioburden. Look for missed canals. If everything looks good and your score is still high, a high score could indicate that you've missed a canal. So go back and look for another canal, maybe take an off-angle radiograph or a CBCT. Confirm that there's no root fractures, because a root fracture will let cells get in. If there's an old restoration there, maybe it's leaking and there's saliva or bacteria getting up underneath there, so maybe remove that old restoration, shore that back up, and then test it. If all that looks good, then I'd go back in, maybe instrument with your files, irrigate and activate some more, then retest, and then repeat if necessary. Again, realize this isn't a judgment about you as the clinician. It's realizing that every tooth is unique. And as you do this more and more, it really becomes fun because you try to get the lowest score you can. And when you get that low score, like in that last one I showed you, when you get like a 5 or a 6 or maybe even a 20, you know that you can take comfort in knowing that you can obturate that canal and everything should heal up fine. So just some tips. When I set up my Endocator, I have my 2 test swabs, which are with the little orange handles in the middle. I have 2 syringes filled with sterile water and 2 sterile syringes ready to aspirate my sterile water out. So after I do my test, I am all set and ready to go. So I've got 2 sterile irrigation syringes, 2 sterile aspiration syringes, and 2 room temperature reagent tubes ready to go. So the question now is ignorance bliss? Not knowing how clean you have the canals could mean your patient's going to suffer when they leave your office. Not knowing what your endoscore is means that an endodontically treated tooth could still fail to heal. Not knowing your endoscore could mean that retreatment is going to be needed, or even, loss of the tooth. So the 10 seconds that it takes to acquire your endoscore could make your life and your patient's life so much better knowing that you have the canals cleaned. So remember, step-by-step success is good and effective chemomechanical canal cleaning, using advanced irrigants, activating the irrigants with ultrasonic energy, and then using the Endocator, which works with all the different protocols of root canal treatment. Because at the end, no matter what protocol you use, you just want to make sure that your canals are clean. So clean and then confirm before you do obturation. Dr. Brett Gilbert, an endodontist, says you can't see clean on an x-ray or a microscope. Very insightful. So Dr. Gilbert is using the Endocator. Dr. Cross, this is an example. What's your endo score? A case study where he got in there and had an endo score of 3 at the finish. He started off with a necrotic symptomatic apical periodontitis type of tooth. 2 visits with, he used triple antibiotic paste, 30 by 06 conservative file, matching gutta percha and endostrength sealer, finished and bonded with the Vista Apex clear flowable, and then the patient at recall is healing up very nicely. So there's these case studies that the endodontists are doing, and we're always doing more and more research, and we'd love to hear what your experience is. When you're done and you with your root canal and you get your endo score, share it with your patients. If you're an endodontist, share it with the referring doctor. I tell my patients, I go, you know what? We tested, once we cleaned out everything out of your tooth, we tested it for any bacteria, tissue, anything that was bad that was left behind. And I got a score of 5, or I got a score of 10. Anything that low is below even the cultural ability of testing. Like we could not withdraw something and culture it and try to see what was in there. The canals are that clean. And so I tell my patients, I go, today we're one of a very few dentists that are able to do this test, but we're trying to make this where everybody will be able to do this test. And it's just sharing the knowledge. So you watching this is one step for us to get closer to that end of having everybody that does a root canal test basically after they've done the root canal protocol and obturation or before they do the obturation, because we would like you to clean, confirm, and then obturate. So I hope you found this information interesting and useful and have fun with this. Thank you very much.